My name is Nick Christelis, and I'd like to welcome you to our lecture on definitions of pain. Now, when you start off in pain medicine, there are a whole range of definitions, and we're going to focus on the important ones. And we might discuss some of the common definitions, such as acute and chronic pain as well, but just to give you an overview of how to approach it. This is the way we're going to structure our lecture. We're going to look at the ISP definition, look at some pros of the definition, look at some cons or criticisms of the definition. We're going to talk about acute pain and chronic pain, just very simply, get an understanding of the two. We're going to briefly mention impairment, disability and suffering, and this may or may not be of immediate relevance to you, but it might be of relevance to those that particularly take up medico-legal work with pain management. And then we're going to get on to the all-important specific definitions of pain. So let's look at the ISP definition of pain. We all know the definition, we all can say the definition, and we've all learned the definition for our primary examinations that we've done. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms thereof. Now, the important things to remember about this definition, as pain specialists, we need to be able to appraise this. So there are three aspects to this definition. It's unpleasant. It's not a nice experience. There's a sensory part of it, and there's an emotional part of it. And it's associated with tissue damage that may or may not be there. Now, let's look at important aspects of this definition. It is 100% subjective. In other words, you can't diagnose pain unless somebody tells you or communicates that pain to you. It needs somebody to report the pain, so it needs self-report by the person. That's the only way you can understand that there is pain. And it depends on the context in which the person is. So in other words, if somebody is highly or psychologically distressed, they may use telling you that they're in pain as a form of communicating their distress. Another type of context you may consider is this pain described clinically or in the laboratory? And we'll get onto this a little later, but this is important. So it's context dependent. It's a sensory experience. In other words, you need to be able to discriminate between various sensations. Now, pain is unpleasant, so those sensations that are not unpleasant are strictly speaking not painful. So paresthesia, which is just an abnormal sensation, whether it's spontaneous or evoked, it's not unpleasant. Whereas looking at something like dysesthesia, an unpleasant and abnormal sensation, again whether spontaneous or evoked, would be considered a painful stimulus or an unpleasant sensation. Another important aspect of pain, or the definition, is that it is a perception, or it's how we perceive this experience that we're going through. And it's not nociception. And nociception is essentially just a physiological process. I'll get onto that definition a little later. I'll elaborate on that a little later. There's a strong emotional aspect to pain, and this is very important, particularly in the hospital setting. We as doctors are very good at diagnosing a physiological process or impairment, but we forget about the emotional aspect. Pain specialists are pretty good at this, as are palliative care specialists, and hopefully the aspect of the emotional aspect of pain of medicine will filter through to various other specialties as time goes on. But again, so it's an emotional aspect. There are affective aspects to it, and there are cognitive interpretational aspects to this. So what this means is, and this is loosely based on Luce's so-called onions of pain, or onion rings of pain, it starts off with nociception. That would lead to the experience of pain. Again, there's an emotional component to that. That would lead on to the patient's suffering. So pain can cause suffering, and we'll get onto this definition a little later. This would lead to a change in somebody's behavior, and this can have implications to the immediate and distant environment as well that the patient is in. So multi-dimensional, multi-layered. I'll just go back there. And another way of looking at it is it can be a sensory discriminative component, so that's the nociception. Then it moves on to a cognitive evaluative type of aspect of the pain that has effects on emotions, so your affect may change. That'll change your behavior or motivation, so there's a motor aspect or behavioral aspect to the pain. That may change the conditioning, and of course that could have implications on your spiritual being. And this is important, particularly when looking at cancer and cancer pain management. We need to take into account the spirituality, or the so-called spiritual pain elements. Now let's appraise, or let's look at the negative features of this ISP definition. So let's look at let's appraise the negative aspects of this definition. The definition conceptualizes the problems into either the body or the mind, but it doesn't allow us to look at these two things simultaneously, and that's important because there are whole multidimensional levels to pain. This definition considers pain in humans only, and that's important because you need to be able to self-report pain. So that moves on to the next aspect, and that's because you need to report pain, there are a number of aspects or people that are incapable of reporting pain. So infants, newborns, young children, elderly, those people that are disabled, people on intensive care unit or heavily sedated, they may be in pain, but they're unable to report it to us. So does that mean they're not in pain? So these kinds of things we need to take into account considering the definition. Animals as well. Animals feel pain, and this definition doesn't allow us to look at pain in animals, in veterinary science. Some of the aspects that this definition doesn't address is it doesn't bring in the acute versus the chronic pain paradigm, which of course is important. It doesn't allow us to consider the physiological aspects or phenomena associated with pain. So for example, the neuroendocrine changes, the autonomic nervous system changes, and the whole or hormonal aspects of pain, or the response to pain. And as I've mentioned before, it doesn't allow us to take into account the psychological phenomena of pain. So the affective aspects of pain, the cognitive, the evaluative aspects of pain, and how we interpret pain. And as I mentioned, it doesn't allow us to take into account your spirituality and the spiritual aspects of pain and facing your imminent death for those people suffering from cancer. It doesn't allow us to assess or consider social, cultural, and ethical aspects of pain, which we all know are incredibly important. Pain behaviors are not looked at. Looking at this definition and seeing patients in the acute setting, in the chronic pain or clinic setting, pain behaviors are very important. Neuropathic pain. This definition has no mention of neuropathic pain, and we'll talk about that a little later on. But essentially, neuropathic pain being associated with tissue damage or damage to the nervous system. So you could read this into the definition, but ultimately it doesn't allow us to describe pain in terms of damage to nerves, or the whole aspect of neuropathic pain. It doesn't allow us to look at the mechanism-based etiology of pain, and this is important because this is the way we're trying to move away from symptom treatment, so dealing from the end backwards and just treating symptoms of pain, where if we can understand the mechanisms of pain or the disease process that we're dealing with, it might be that we can focus our treatment at an earlier process. It doesn't allow us to look at the meaning or purpose of pain, and it also doesn't allow us to consider suffering, and we'll get on to suffering in a little while. So let's look at acute and chronic pain. Now we all know that acute is there, it's short-lived, and chronic is long-lasting, but let's, as pain specialists now, really appraise the difference. Acute pain, you consider it as a nociceptive type physiological pain, so there is damage to tissue or parts of the body, and that leads to nociception occurring. This is generally a short-lived process. In other words, when the tissue heals, when the inflammation reduces, the pain should disappear, the pain should settle down. Acute pain is considered on an evolutionary scale that it would be an appropriate response to acute tissue injury, in that when we hurt, when we have surgery, when we break a bone, we want to curl up and be quiet in a corner, and that allows us to essentially heal. And that has an appropriate and adaptive biological response to this injury. Acute pain, strictly speaking, there's no change in baseline neuronal activity. In other words, the nervous system, the body functions as it should. And you could consider acute pain a symptom, so it's a symptom of an injury. And the things that can cause acute pain include acute trauma, acute surgery, burns, acute medical diseases such as zoster. These are the kinds of things that would be associated with an acute process. Now, acute pain can also be associated with impairment, which means part of the body is not functioning as it physiologically should, and we'll come to that definition in a little while. Now, looking at chronic pain, depending on where you look at it, the definition may range from pain lasting more than a month, pain lasting more than 3 months. The definition of chronic post-surgical pain uses a 2-month cutoff. If you look at the definition as by William McRae in the British Journal of Anaesthesia. So the key with chronic pain is it outlasts the tissue healing. That's a better way of looking at it. Generally speaking, chronic pain is a neuropathic pain. It's a long-lasting pain. There's elements of sensitization of the nervous system. There is nothing good about chronic pain. There is nothing evolutionary useful about chronic pain. There might be, we may learn about this in the future, but at the moment we would consider chronic pain a maladaptive response. The neuronal baseline activity is abnormal. In other words, the nervous system changes, or the somatosensory system changes, and this is an abnormality. This is not normal. It can be a symptom or a primary disorder. In other words, chronic pain could be a primary illness in itself, and this would include disease processes such as fibromyalgia. And chronic pain can lead to suffering and disability, and this is important. This is the multidimensional aspect of pain, and I'll take you back to Luce's onion rings of pain, and that chronic pain has implications in a wider physiological aspect. In other words, it can lead to suffering, it can lead to changes in behavior, and of course have implications on the environment. Let's look at the differences and definitions between impairment, disability, and suffering. May be important to you. You may be associated with medico-legal aspects and be asked to assess a number of patients with pain and look at their levels of disability. So nevertheless, it is important to understand these definitions. Impairment, I consider impairment, or one should consider impairment, as a loss of function, loss of physiological process in the part of the body. So if somebody breaks their leg, that leg is impaired, it's not functioning well. Now, impairment could lead to disability. Now, disability could be considered when a person is unable to act within what society deems the normal range of function. So impairment could lead to disability, and excessive pain can cause disability. But strictly speaking, pain shouldn't lead to an impairment of part of the body, and this is an important definition or difference to understand. Let's look at suffering, and there's quite a big definition in your reading package. It's a negative cognitive and emotional response to negative existential states. And these negative existential states could be things like fear, anxiety, pain. So pain can cause suffering. I think of pain as just a negative response following a threat to one's self or integrity of self. And this is important. So if people feel threatened, if people have cancer, if people have loss, bereavement, they could suffer. So pain is one of the causes of suffering. So pain can lead to disability, pain can lead to suffering, but pain, strictly speaking, shouldn't lead to impairment. An example of this structure is looking at the WHO model of disability, and it looks at a number of domains, and as you can see there, it considers impairment under body function and structure. That can lead to, so an impairment of body function or structure can lead to a limitation in a particular activity, and that can lead to restrictions in things like enjoying life, participating in school. And there are a number of aspects of a number of domains that affect these limitations, impairments or restrictions. This includes environmental, like external factors, as well as personal factors. Right, let's get on to the crux of this all. You want to know about the definitions of pain. So the first group of definitions, and this comes from an excellent paper by Lusser and Treed out of Pain in 2008. You'll have the reference. It's not a very long paper. It's about 4 or 5 pages long, and the table that I will be showing you, or that you've got in your reading material, is a reproduction or adapted from that paper, and there are a couple of introductory pages that might be worth a read. So, nociception, nociceptor, nociceptive neuron, it all comes down to the same thing. This is a physiological process. This is something that's going to happen whether the patient's awake, whether the patient's asleep. You have a noxious stimuli that is going to cause actual or potential tissue damaging event. Now, I have slight issues with that. A noxious stimuli could potentially damage the tissue. I suppose that's true. If you take a flame and you put it near the skin, it could potentially injure the skin. Now, that may not lead to nociception yet, but once the skin is damaged, you're going to get nociception. So the nociceptor is a neuron, or is a receptor that's able of transducing that initial event into a signal, and that would be a noxious signal. Nociception, should I say? Nociception, encoding and processing of a noxious stimuli. Nociceptive pain is pain due to activation of nociceptors. So that's pretty self-explanatory, and that's pretty easy. It's a physiological process, and those are aspects of this process. Neuropathic pain, there will be a chapter, a topic on neuropathic pain, but let's look at the definition itself. Now, the previous definition was pain initiated or caused by a primary lesion or dysfunction in the nervous system. That word dysfunction has been removed from the definition, or the current definition of neuropathic pain. The way we should now define neuropathic pain is pain arising as a direct consequence of a lesion or a disease affecting the somatosensory system. Now, looking at neuropathic pain, and this is difficult because it's recommended that we should have 4 things before we diagnose neuropathic pain, and we always diagnose neuropathic pain, or most of the time diagnose neuropathic pain, not considering all 4 aspects. But strictly speaking, diagnosis of neuropathic pain should include a history of a disease or lesion. So something should have happened to damage the nervous system. The patient should complain of symptoms in that anatomical distribution of the nervous system, or that anatomical distribution of the damaged part. There should be signs and features of neuropathic pain. So that may be the negative features of neuropathic pain, the dysesthesias, paresthesias, the numbness, or the positive features, the hyperalgesias, the allodynias, the autonomic nervous system changes that occur. And the 4th aspect is to have a diagnostic test, so you should be able to diagnose that lesion or disease. Another way of looking at it all, of neuropathic pain, is because we don't have a diagnostic tool, we should consider the grading system for neuropathic pain. Is this definite neuropathic pain? Is this probable neuropathic pain? Or is this possible neuropathic pain? So if you see a patient in clinic or in an acute setting and you diagnose neuropathic pain, consider these aspects to support your diagnosis. Another aspect of neuropathic pain is the difficulties in diagnosing neuropathic pain. This is a subjective experience. It's going to change. Symptoms change, signs change with neuropathic pain. It's difficult to separate the peripheral nervous system from the central nervous system. And of course, there's no gold standard test to diagnose neuropathic pain. There are a number of neuropathic pain special interest groups, particularly as a chapter of the IASP, and as yet there is still no consensus by our expert colleagues. But hopefully they'll get there. Now, let's just mention the word dysfunction. That has been removed out of the definition of neuropathic pain. And that now could be considered as a pain in it, or as a definition in itself. And a dysfunction is diagnosed as, I'll just read it to you, pain in the absence of a lesion of the nervous system. And that could either be an idiopathic cause, or of course the disease processes such as fibromyalgia or somatoform abnormalities, which we'll get to at a later point. Now, sensitization. This is important. When we use this word or these terms, we need to understand how we're using them. So, sensitization is an increased responsiveness of the neurons to their normal input. So that's a normal neuron responding excessively, or it's a recruitment of a response to a subthreshold input. So it's a neuron that is responding to a subthreshold input. That's a pretty important difference to understand. Now, what happens in sensitization, these are the things that happen to the nerve when they undergo sensitization. As I mentioned, there's an increased response to the normal input. The basal level of activity of these neurons is heightened. The threshold that they need before firing occurs is dropped. There's a suprathreshold response, so there's again an excessive response. There are after discharges, the pain lingers, or these discharges linger after the initial stimulus or response. There is an expansion of receptive fields. In other words, it engages normal tissue, normal receptor and receptive fields, and this is brought into the aspect, so you get widespread pain, widespread features of neuropathic pain, allodynia, hyperalgesia. There is spontaneous activity, and this is important. And the stimulus-response curve shifts to the left. So at the same stimulus, you have a higher response. And of course, sensitization, like neuropathic pain, can be either peripheral or central. So sensitization could be considered an amplification of nociception, and that's a good way of remembering it. Now let's look at allodynia, hyperalgesia, hyperpathy, and wind-up. Allodynia, pain in response to a non-nociceptive stimulus. You just need to know this. It's something that's not painful that causes a painful response. Now, there are different types of allodynia. Fancy terminology, dynamic, tactile, mechanical allodynia, which is, as I said, fancy terminology for brush allodynia. So in the clinic, you take a little paintbrush, you brush the skin, see what happens. This is the way I assess allodynia in the clinic. There's static mechanical allodynia, which is a fancy terminology for using fluffy cotton wool, fluffy clouds, dabbing it on the patient's skin and seeing if that causes allodynia. And of course there's thermal and deep somatic allodynia, so squeezing muscle and tissue deeply can sometimes cause allodynia. Hyperalgesia, this is an umbrella term. That's the umbrella to remind you to remember this is an umbrella term to define an increased pain sensitivity. So it's a painful stimulus that causes an increased sensitivity to that. There are different types of hyperalgesia. There's the clinical setting, there's the laboratory setting. In the clinical setting, you could either use hot or cold rollers, or cool or warm rollers, should I say. You could use capsaicin cream, or a toothpick, and this is the way most diagnose hyperalgesia in the clinical setting, using a toothpick. So pinprick hyperalgesia. And then in the laboratory, there are a number of aspects or a number of things that can be used to diagnose hyperalgesia in that setting. Hyperpathia, wind-up, I consider them the same but slightly different. I think most use the term interchangeably. Hyperpathia is a clinical pain syndrome. You have a repetitive stimulus leading to a delayed and excessive explosive response with radiation after sensations, so those features of sensitization. There's the bang, there's that explosive response to hyperpathia. Wind-up can be considered a clinical or an experimental paradigm where you get excessive pain sensitivity, so hyperalgesia, to repetitive stimulus, strictly speaking, less than or more than half a hertz, less than 10 hertz. And again, it's a non-linear response with an explosive response following that. I just want to briefly mention why dynamic range neurons. Those are neurons that respond to a wide dynamic range of input, so noxious and non-noxious input. And these wide dynamic range neurons converge, have a wide receptive field, and these are important and brought into play in hyperalgesia and allodynia. Let's look at definitions of pain tolerance and pain threshold. So on the x-axis we have stimulus, and on the y-axis we have response. Pain threshold: the minimum intensity of a stimulus that is perceived as painful. So the tiniest stimulus that somebody needs, after which they say, or at which they say, I can feel pain. And the pain tolerance level is the maximum intensity of a stimulus that evokes pain that the subject is willing to tolerate. That concludes this topic.